Hello, everyone, and welcome to today's industry webinar, an overview of ONC's Cures Act final rule. My name is Ellen Knowles, and I'm the Marketing Communications Manager here at Azalea Health, and I will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using their computer audio system by default, but if you would prefer to join over the phone, just select telephone and the audio pane on the right-hand side of your screen, and the dial-in information will be displayed there. I want to note we will not be having a live Q&A session today, but instead we will direct you to a questions portal hosted by ONC where they can collect your questions and answer those accordingly. We will share the link to this portal in today's presentation, and you will also receive a copy of today's slides and a link to the webinar recording following today's event. I would now like to introduce our presenters today. We have Rachel Nelson. Rachel is a senior advisor and team lead in ONC's Office of Policy. She practiced health services administration and care quality improvement in both rural Ohio and Medicare's QIO program before joining ONC in 2008. And next we have Stephanie Lee. Stephanie is a public health analyst within the Office of Policy at ONC. She has contributed to developing several regulatory matters primarily focused on the ONC Health IT certification program. And with that, I'll go ahead and turn today's presentation over to you, Rachel, to get us started.
Good afternoon, everyone. Thanks for joining us and giving us an opportunity to say a few things about our role. From the outset, I want to highlight that this is an overview presentation, so we are hitting the high points. There is a lot more detail, a lot more information available, and we will show you at the end the web link that Ellen mentioned and where you can go to find the information, as well as the link to the question portal. The goal of this rule is very simple. It's all about access and choice for patients to access their electronic health information at no additional cost to the patient, and for providers to be able to choose the IT tools that help them furnish the best care without excessive costs or unnecessary technical barriers. This slide touches a little bit on why this rule matters. It helps provide patients access to their charts in novel and more modern ways, like patient-selected apps, while still protecting patient privacy and security by requiring industry-standard technical security requirements as part of certification, and enabling patients to choose which data in their medical record they authorize an app to receive. Patient healthcare providers and other stakeholders are also permitted to educate patients on privacy and security matters without implicating information blocking. The rule also enables patients to shop for care and manage their costs, in part by making it so much easier for them to get their information through things like smartphones and apps of their choice. The rule matters to doctors and hospitals. It makes responses to patient data requests easier and less expensive, because patients will be able to access their health information from EHRs using those apps of their choice in an automated fashion without eventually, once all of the rules or provisions are implemented, without additional actions on the part of the provider or their personnel once the technical capabilities are in place. It also makes a difference in allowing more choice of software so that providers can more easily choose which software they want to use, and to benefit from a vibrant marketplace of software services. It also helps to improve patient safety by permitting the sharing of patient safety concerns arising from certified EHRs. This helps it also helps protect patients and others by recognizing practices that prevent the sharing and use of health information when such sharing might actually cause harm, and that is done through the preventing harm exception for information blocking. This rule also matters in supporting improved patient matching through the exchange of the US CDI and its patient demographic data elements. Next slide. The agenda today, Stephanie, in a couple minutes, Stephanie's going to talk to you about the updates to the 2015 edition certification criteria, the newly established condition and maintenance of certification requirements that apply to health IT developers who participate in our certification program. I'm then going to talk to you just a little bit about information blocking and provide that information we were talking about on where to get even more information or ask ONC a question. The last point I'm going to touch is the reminder note that the materials in this presentation are based on the regulatory provisions we finalized in 45 CFR parts 170 and 171. Please remember that although we have made every effort to make this an accurate statement of what the rule means, this presentation and what we verbally say today are not legal documents. The legal requirements are established in the rule, and the rule is the legal document. This particular presentation and my time and Stephanie's is brought to you courtesy of US taxpayer expense. And with that, I will hand it over to Stephanie.
Thanks, Rachel. So we can jump straight into the updates to the 2015 edition certification criteria. So just for some broader context with the scope of the changes, which we will also go into further detail on the following slides. This slide is kind of a snapshot on the updates that we've made to the 2015 edition that we've kind of broken down into several buckets that you can see. So for some of these criteria, they've been designated as what we're calling as time limited. And what that generally means is that even though they won't be officially removed, these criteria will basically no longer be available for certification after a certain period of time. So they are basically designed to sunset along with their use in the Medicaid EHR incentive program. And then there are other criteria that are being removed entirely. As you can see on this slide, that includes things like problem list, medication list, med allergy list, smoking status, and these are generally being removed entirely because we've seen that they typically already exist within technology to such an extent and are so prevalent that it doesn't really make sense to have just one version to be tested when there are various versions that are already working well for providers and that are already included in technology that they're purchasing. And then some criteria and then other criteria are being removed because they are either being replaced with something else like an update or an expansion to the standard or criteria, or there's like a new version of the certification criteria itself that will replace the old. And then the next bucket is what we call revised criteria. And this includes criteria like what we call the interoperability criteria. This includes like the CCDA, the view, download, transmit, and the API criteria. And so these are being updated with what Rachel mentioned earlier, the US CDI, which we'll also go into further detail. And then some are being updated with the CCDA companion guide. And then there's also several criteria that have just been revised to include kind of like a modification to the underlying standard. And those criteria like the security tags, send and receive criteria, the electronic prescribing, and the clinical quality measures. So the scope of those revised criteria are really about trying to make common sense updates to the existing criteria. And then the last bucket on the bottom is that we also have several new criteria. These criteria are somewhat based on the criteria that we have removed that I mentioned earlier. They're not often direct correlations, but they do build on prior concepts like the electronic health information export, the standardized API for patient and population services, and the privacy and security attestation criteria. So this is what we mentioned earlier. This is the USCDI, which stands for the United States Core Data for Interoperability Standard. This is the standard that will replace the Common Clinical Dataset, which was the prior sort of list of things that were required to move from point to point. So the USCDI basically expands the Common Clinical Dataset to include a few more data classes and elements that are currently used to promote things like patient safety and coordination and quality of care. So as you can see on the slide, the 4 data classes that have been updated is provenance, clinical notes, pediatric vital signs, and address, email, and phone number. And with the last one, I just want to highlight that since those are all demographic instances that are used to support patient matching. And another important thing to highlight is that the USCDI is sort of coexisting with the CCDS for now, but we do expect afterwards that it will become more of the baseline set of data that is moving across systems. So as I mentioned before, we also revised the electronic prescribing and clinical quality measures. These 2 criteria align with CMS programs and CMS requirements. The e-prescribing has been updated to use the NC-PDP script standard, version 2017-071, and that's largely in part because Part D has started requiring this for Part D electronic prescribing transactions beginning January of this year. And for CQMs, this revision is for C3 only, which is the reporting criteria. If you're already familiar with our program and criteria, we have removed the HL7 QRDA reference and instead replaced it with the CMS QRDA implementation guide. And so again, for those who are already familiar with that, that's what you're already using to report to CMS. So this is simply a streamlining. This is a way to simply streamline testing and what CMS already requires for submission. So we've also revised the security tags. So these 2 criteria, we've changed the name of the 2 current 2015 edition data segmentation for privacy criteria. So these 2 criteria, they support the ability to tag a CCDA either at a sending point or to be able to receive or interpret tags for the purposes of supporting segmentation activities. And although they don't meet the whole scope of the needs for segmentation, we have adopted the full HL7 standard here so that it can be tagged at the document section and entry levels. And the intent here is to preserve the granular privacy marking capabilities, specifically looking at specialty settings such as behavioral health, opioid use, and pediatric care. So this one is a new certification criterion called the Electronic Health Information Export. And this criterion has been adopted with a focused definition that aligns with the EHI definition that we have adopted for information blocking that will be further explained later. So that definition is the EHI that is electronic protected health information to the extent that it would be included in the designated record set. And this is in direct relation to the HIPAA definitions. And for certification purposes, developers are required to ensure that their health IT products are capable of exporting the EHI that meets the definition above, that can be stored by the product at the time of certification. And just a quick note on these general requirements, we do include 2 use cases for this, as in a certified health IT module must include export capabilities for a single patient EHI export to support patient access, as well as patient population EHI export to support transitions between health IT systems, like moving across systems, switching to a new product, or moving from one setting to another. And then the export files that are created, they must be electronic and in a computable format. And there needs to be publicly accessibility to that format. So we said that there needs to be a publicly accessible hyperlink so that others can actually get to that format and be able to consume the data. We also have the new API criterion, and just to point out some highlights with this one, so we've established this new certification criterion that requires health IT developers to support standardized APIs for single patient and population services. An important thing to note with this is that we have adopted the FHIR Release 4 as the finalized standard, which we expect the use of the standard will help to allow for more innovation, basically, in the app marketplace because of the removal of the burden to develop to multiple proprietary standards. And the last piece here is the new privacy and security transparency attestations. So these are 2 criteria for privacy and security, the encrypt authentication credentials and the multi-factor authentication. These are yes or no attestation criterion for developers. So developers would come in and attest to whether or not they use encrypt authentication credentials or multi-factor authentication. And since there are many good reasons to why a developer might not do one of these things in a specific manner, we do allow developers within the space of the attestation to kind of provide an explanation and as to whether they do things differently or if they attest no. So that was it with the highlights and the overview for the updates. And now I will jump into the newly finalized conditions and maintenance of certification requirements. So again, this is just a high-level overview. In the interest of time, we'll touch on the highlights of these requirements. But again, as mentioned before, we have other specific webinars available that focus specifically on this topic. So we recommend you to listen if you are interested in finding out more in-depth details. So for some background, the 21st Century Cures Act requires HHS to establish conditions and maintenance of certification requirements for the ONC Health IT certification program. So on the right side, you can see that we have 7 conditions of certification with maintenance of certification requirements, 6 of which we have finalized in this final rule, with the 7th going to be at a future time. So the first condition of certification is information blocking. This condition applies solely to developers of certified health IT only. So information blocking will be discussed later on in more detail, um, which applies more broadly to a developer certified health IT's actions related to access, exchange, and use. But in the context of the program with this condition, we're focusing on those actions related to their certified health IT. So this condition is pretty straightforward. We didn't add a maintenance requirement or propose one either. So the second condition of certification is what we call assurances. This one is essentially 4 conditions that are set out with 2 maintenance requirements. The first one basically tracks the statute. What we're saying here is that developers will test that they do these certain things and comply with the requirements that we set out. So this includes information blocking as well as any other action that may inhibit the appropriate access, exchange, and use of electronic health information. And then we have 3 specific conditions as well that fall under the one laid out in statute, which is full compliance and unrestricted implementation of certification criteria capabilities. Generally, this has always been a requirement of the program, but this is saying that, you know, once a product is certified, it's expected to always maintain compliance, both in the field and production environment, as well as not to restrict the functionalities for its customers or users. And then the certification to the electronic health information export criterion. Basically, with this condition, if a developer brings certified health IT that electronically stores EHI, then they have to get certified to the new EHI export criterion. So as a condition, a developer must certify to it and provide that functionality to their customers by and after 36 months after the publication date. The next condition is the communications condition of certification. Again, as the statute lays out, this condition is that a health IT developer may not prohibit or restrict communication related to the 6 subject matters here you see on the screen. So that's usability, interoperability, security, users' experiences when using the health IT, businesses' practices of developers related to exchanging EHI, and the manner in which a user of the health IT has used such technology. So the purpose here is to make sure that there can be an exchange of health information ideas and to make sure developers are not improperly restricting any of those protected communications for their customers. And again, this is in respect to certified health IT under the program. So this can include both written or verbal communications, but this can also include visual communications. For example, screenshots or videos on YouTube could potentially fit under this condition. But an important thing to note is that we have also finalized provisions that permit developers to impose certain types of limited prohibitions and restrictions as well. We try to strike a balance between the need to promote open communication about health IT and their business practices, along with the need to protect the legitimate business interests of health IT developers and others. And then also worth noting are the maintenance requirements. So developers only have to update or amend contracts when the contract or agreements are modified for other purposes. And developers must notify customers that any communication or contract or agreement provision that violates this communication condition will basically not be enforced. Next, we have the application programming interfaces, the APIs. So this is the fourth condition of certification. And this condition only applies for developers that are certified to any of the API criteria, which if you're familiar with our program, it's G7 through G10. And then you can see on the right side that we've tried to identify the roles and definitions in the terms of the requirements to kind of provide clarity, such as we define certified API developer, certified API technology, API information source, and API user. And an important thing to note with this condition, again, it's the USCDI, which is the scope of data we're looking at when we talk about the APIs. Okay, next, so these are the actual conditions that are highlighted as well in our API conditions of certification. So we include conditions that are about transparency, fees, and openness, and that promote pro-competitiveness to promote an open and competitive market. And as you can see here, we also finalized a few API maintenance of certification requirements, which again, these address ongoing requirements that must be met by certified API developers and their certified API technology. So in the interest of time, these kind of speak for themselves. So I'll move to the next condition. So the fifth condition is the real world testing. This condition is about making sure that these functionalities that are certified continue to actually work as anticipated in the field. So it requires developers to test their products in a real world setting and also to comply with maintenance requirements like submitting a real world testing plan. So that can include things like scheduled key milestones, as well as explaining like what kind of settings in which it'll be used. So developers submit their real world testing plan and they also submit the results, and these will be available on the chapel. And developers will also notify ONC-ACBs of any nonconformity with program requirements as well. So an important maintenance requirement to highlight with this condition is it's called the standards version advancement process. And basically the hope for here is to basically let the market lead, which is we don't wait on regulations to be able to move on to newer and improved versions of standards and implementation specifications. And so basically what we did is we set up a process for developers to be able to move on to new versions if they and their customers want to. And so to do this, they would also need to real world test it and have it part of their plan, and that they're also attesting through our attestation process that their product can actually do this new version. So that in turn also provides assurances to their customers that these things are working as they are planned. And the final sixth condition, this one is called the Attestations condition of certification, which we've kind of touched on throughout this section. And this is basically an attestation as it applies to a developer. So basically, a developer will need to attest to any to the applicable conditions and maintenance of certification requirements that we just went through. For example, if a developer doesn't certify to any of the API criteria, that developer also wouldn't be expected to attest to the API conditions of certification. However, all developers will be expected to attest to the communications condition of certification, and we lay all of that out in regulatory text. And then, as you can see on the date on the right, the first attestation period will begin April 1st, 2021. And then after that, developers will be required to submit their attestations every 6 months. And just to quickly go over enforcement, we have finalized to basically utilize the processes established for ONC direct review of certified health IT for enforcement of the requirements for certified health IT developers. And we lay out the general process of what an enforcement case might look like for the conditions and means of certification on this slide, broken down into 6 main steps, which is review a health IT developer notice, records access, corrective action plan, certification ban and or termination, a step for appeals, and then finally a public listing of certification ban and or termination. And that's kind of a very broad overview on what ONC's direct review of what the conditions and maintenance of certification may look like. And from here, I'll hand it back to Rachel.
Yes, thank you, Stephanie. At this point, I do want to take a rhetorical yet deliberative pause to focus for a moment on a key difference between the technical and other certification program requirements that we just reviewed. They have meaning and are important for providers, but they are fundamentally different from the information blocking provision in a couple of ways. The information blocking provision applies to healthcare providers as well as health IT developers of certified health IT, health information networks, or health information exchanges. Information blocking is also not a requirement to conform to specific technical standards or do things in particular technical ways. Instead, as you can see on your screen, information blocking, which is what is prohibited by the information blocking provision of the Cures Act, and that we have implemented in regulation in 45 CFR Part 171. Information blocking is a practice. It is something you do or don't do that is not required by law and does not fit within one of the exceptions that are defined in regulation in 45 CFR Part 171. And if done by a healthcare provider, is a practice that that healthcare provider knows is unreasonable and is likely to interfere with the access, exchange, or use of health information. What you're looking at on the screen is what applies to everyone, whether you're a healthcare provider, a health IT developer, or health information exchange or network. There's a slight difference in the definition that applies to health IT developers of certified health IT and to health information networks and exchanges, in that the practice must be one that they know or should know is likely to interfere with the access, exchange, or use. So there is a slight difference in the details of the definition of information blocking, depending on whether you are a healthcare provider or another kind of actor covered by the provision. And again, I want to emphasize that it is a fairly simple definition. It is simply do not do things that you know are unreasonable and likely to interfere with the access, exchange, or use of your patient's health and electronic health information. We'll touch briefly in a moment on the 8 exceptions that are defined in regulation at the moment. But first, I want to talk a little bit more about the definition of electronic health information. We heard from public commenters that it's important to align as much as possible across the various HHS regulations, including between information blocking and the HIPAA rules. The finalized definition of electronic health information accomplishes alignment, and it lands on a definition that should be very familiar to the majority of healthcare providers, as well as to health IT developers and networks and exchanges that serve those providers' exchange and health information management needs. The final definition of electronic health information for purposes of the information blocking provision can be found in 45 CFR Part 171, Section 102. It is simply electronic protected health information to the extent that that electronic protected health information is included in a designated record set, as these terms are defined and understood for purposes of the HIPAA rule, including specifically the HIPAA rule's right of access for an individual to their protected health information. One distinction is that protected health information, the HIPAA rule, is specific to HIPAA covered entities. However, the information blocking provision applies to healthcare providers, whether or not the healthcare provider is also a HIPAA covered entity. That's a pretty small percentage, relatively speaking, of healthcare providers. But those few that may not be HIPAA covered healthcare providers are still, if they are a type of provider within the definition established in 45 CFR Part 171 for information blocking, still expected to not interfere with the legally permissible access, exchange, and use of electronic health information, which is information that would be EPHI within a designated record set if it were held by a HIPAA covered entity. And that was a lot in a short period of time without a lot of things to look at. I want to highlight again, and we've stressed a couple of times, but I think it's worth repeating several times, at healthit.gov/cures rule, you can easily find a link to the full text of the final rule itself, plus fact sheets and recorded webinars and the slide decks from those webinars that take deeper dives into information blocking in specific, into other pieces of the rule in specific. Now, I talk a little bit about the exceptions to information blocking, which we have established consistent with the provisions of the Cures Act, for the Secretary to identify through rulemaking reasonable and necessary activities that do not constitute information blocking for purposes of the information blocking provision. And those exceptions we have chosen to organize, and in order to make it easier to talk about them, into 2 different basic categories. They can be thought of as one grouping of exceptions that involve potentially not fulfilling requests to access, exchange, or use EHI at all. And another category that can be thought of as exceptions that involve procedures for fulfilling requests for access, exchange, or use of electronic health information. I'm really not going to touch much on any of these exceptions here. This is a view from orbit in space of what these are. I mentioned earlier the preventing harm exception, and therefore I will cycle back to that. And that particular exception it is aligned very carefully with the HIPAA privacy rule, right of access provisions, so that in circumstances where potentially both the privacy rules, you could deny an individual access under the privacy rule, right of access to their PHI in order to prevent harm to themselves, to the patient, or to another person. The standard for what kind of harm would be risked is the same when if the practice is going to interfere with otherwise legally permissible access, exchange, or use of EHI, specifically in order to prevent harm to the patient or another person. The privacy exception likewise is carefully aligned to the HIPAA privacy rule. The security exception is aligned with the HIPAA security rule. But I would encourage folks to look at the other webinars we have put out and to read the regulation text itself, because the privacy exception and the security exception do have particular conditions that one would want to meet. The infeasibility exception is, in short, there to cover situations where a request to access, exchange, or use is simply not feasible under the circumstances. And one of the more memorable types of circumstances that is specifically addressed in there is, for example, if the provider or their system has experienced a natural disaster and you simply cannot respond to requests because your system is down and it will take time to get it back up. We also have an exception that recognizes and covers, provided its conditions are met, practices such as taking the system down for maintenance at reasonable time periods to maintain and enhance the performance. It also applies to practices such as potentially throttling or metering access by particular applications in order to maintain core functionality of the system. So requests, demands for operational capacity from a more ancillary application or an outside application can be throttled down and held back in order to prioritize the core functions of the system that you need in order to safely and effectively provide patient care. The exceptions that involve procedures for fulfilling requests are things like the content and manner exception, which provides a procedure to go through if someone asks for an access, exchange, or use in a format or a manner that you can't support. This provides a structure to walk through. The fees exception is very detailed, and it covers for recouping some costs for providing infrastructure and for enabling certain types of health information exchange. The one thing that I want to make sure folks recognize is that under the information blocking rules, the fees exception would not apply to charging a fee to a patient to access their own record. We believe that patients, and we have finalized these rules consistent with that belief, patients should be able to get a copy of their own chart out of that EHR without having to pay additional costs just to get that information out. And the licensing exception provides for those circumstances where, in order to achieve access, exchange, or use, it may be necessary to license particular technology or intellectual property, such as a particular code set. Again, those interested in taking a deep dive, I highly recommend starting with the rule itself and then going to the other informational resources we have provided. If you have questions, we are going to encourage you first to look at our website and the materials we've already provided, but if that still doesn't answer your question, please don't hesitate to use the inquiry portal that we are going to show you at the end. This timeline encompasses a couple of different things. It shows the timeline for certification, the key milestone dates. You know, in the rule, we've talked about, in other places, we've talked about how many months after publication of the rule. In the rule, there's also dates that have been calculated out once the publication date was established on May 1st of this year. This timeline shows you where those dates fall on the calendar. And I do want to point out something that has come up in other webinars that we've done and other questions we have received about the relationship between the certification timeline and the information blocking timeline, specifically related to the US CDI. And that is simply that when we speak about the US CDI in context of information blocking, it is functioning as a definition of the types of information that an actor has to would be expected to provide legally permissible access, exchange, or use of in those contexts and for the time period where information blocking can be satisfied by providing the types of information described within the US CDI. For the purposes of information blocking, that provision of the types of information within the US CDI does not have to be in full accordance with the standards and implementation specifications referenced in the US CDI and its data elements that will be required on the certification timeline and eventually will be available to all healthcare providers using a certified health IT. As a technical standard, the US CDI operates in certification, and within information blocking, it defines or describes the types of information that are expected to be available for access, exchange, and use. The other thing that I want to mention, you may have heard that HHS announced enforcement discretion related to certain timelines within our cures rule, specifically in recognition of the COVID-19 situation, and you do not see those on this timeline. There is a specific page on our website that provides information about enforcement discretion, including a fact sheet that addresses the specific dates within the rule. And at this point, we are at the conclusion of the substance, with the exception of, as promised and advertised, moving to get more information, here is the web page you want to start on, healthit.gov/cures rule. And under the resources tab, you will find the fact sheets, webinars, and as I just mentioned, go down to the very bottom of that drop-down box, and that is where the enforcement discretion information link is. The other thing, if you have questions about the rule that you would like to get an answer from ONC, or if you have other feedback, we have a portal for inquiries and feedback, healthit.gov/feedback. There is a dedicated category. Just click the button if your question or feedback is about the Cures Act final rule. As you can see from this slide, there are other categories. If you have questions or feedback in these other categories, please feel free to put them in there. But if your question in any way is about how the rule relates to anything or what the rule's implications are for any particular topic, it'll get routed to the right people to look at it most quickly if you put it in the Cures Act final rule category, because that is basically how we use the categories, is to facilitate efficient routing of the inquiries and the feedback. And with that, I am going to turn it back over to Ellen.
All right, thank you so much, Rachel and Stephanie. Before we conclude, all attendees, just a reminder, as Rachel just mentioned, please take a moment to write down your questions and submit those to the ONC portal following today's webinar. I want to once again thank our presenters, Rachel Nelson and Stephanie Lee, for the informative presentation today, and a special thanks to all of our attendees for joining us. As a reminder, the presentation will be shared in a follow-up email, which will also include a link to the recording of this webinar in case you want to review again or share with any of your peers. On behalf of Azalea Health and our presenters, thank you for joining us and have a great rest of your day.